Lecture part 2.
0.5.
Here's my 10 people. Alright. Welcome to my 45-minute lecture on locating the MI. My name is Kevin. Welcome to this lecture. I'm glad that you're here. I hope we can get something out of it. Everybody can together. A couple things first. Our objectives. We want to be able to identify an MI, define what it is, and of course tell how to locate it and its best method of location and why it's important to locate the MI. Okay? First of all, what is an MI? An MI, in layman's terms, would be basically a heart attack. Okay? MI is a myocardial infarction. It's a blockage of one or more of the vessels that feed the heart. Most of the pain is caused during an MI that people feel is the heart being deprived of the oxygen feeding the tissues. So your classical chest pain and in my chest and in my jaw and my arm. That's just your body's way of telling you that the heart is being deprived of some oxygen and you are beginning to develop some damage and maybe some actual death. So let's look at some causes. Okay, causes of an MI. Family history. Family history. Can it be changed?
No.
No. Okay. So when I say family history, if you look at people who have parents and grandparents with heart problems and have had a heart attack or a blockage of some sort, a cardiac issue at a young age. There's some people that have had cardiac events very early on, anywhere from a month old on up. So that plays a part, and you can't change that. It just is what it is there. Your diet. The old saying, you are what you eat. Can your diet be changed, Hunter?
Yes.
Okay. So high salt, high sugar is good, right?
No.
Yeah. Bad, right?
Very bad.
So as we control what we eat, we can also help control and offset an MI. Hopefully. Exercise can be changed. You can make sure that you're getting plenty of exercise. It's not just like a strength building, but an aerobic, where you're actually getting your heart rate up, exercising your actual heart, because it's like a muscle. One other thing I have are pre-existing factors. It kind of falls under the family history, but more along the lines of what you're born with. There are a lot of people on this planet that are born with issues that never know it until after their death. There are some that are born with it and they're found out within the first hours or so of life. So with those four things, the family history, the diet, the exercise, and the pre-existing factors, those are four things that contribute to the MI. So we want to try to reduce as much of that as possible. Signs and symptoms, Hunter.
chest pain,
chest pain. Anywhere else?
shortness of breath, arm pain,
Arm pain.
females.
Diaphoresis.
Yep. Yep. Does it have to stay in one spot?
It can radiate.
Okay. Some people would describe it as pressure, like I got an elephant sitting on my chest and I can't breathe. Okay, that's a very ominous phrase to hear in the back of the truck. Ask them on a scale of 1 to 10. Boom. Does it change? Does anything make it better or worse? Does it radiate any shortness of breath? Are they pale? Are they sweating? Are they diaphoretic? Men versus women too. Like women, for some reason, they can have an MI and have pain in their pinky toe. I swear. I mean, it's just like anywhere on their body. I've seen women with my wrist has been numb for a day or two. Do a 12 lead. When in doubt, always do a 12 lead, male or female. But females are more prevalent to have pain elsewhere, and it be in MI. I haven't researched that to try to figure out why, but I'm sure if I did, I could probably figure it out. So, how do we detect an MI? What tells us that normal chest pain is an actual MI? How do we decipher from
A 12 lead.
Yeah.
EKG.
EKG.
Yep.
Labs. Labs are the most definitive means.
Elevated troponin.
That's correct. Cardiac biomarkers, as they're commonly referred to, not just good old what people say. I checked his labs and his enzymes are high. Most ED docs don't like you to say enzymes; they prefer you to say cardiac biomarkers. It's the troponin. They're looking to see if it's elevated. Elevated shows some form of damage to the heart muscle itself. So there are parts of the heart that's affected: inferior, septal, anterior, and lateral. The best means of pinpointing where that MI is in the field is an EKG. The EKG will show you and tell you where the actual infarct is, or give you a good idea as to where. And why is it important to know where?
We'll see what side of the heart's damaged.
It also affects your treatment. Not really, but just somewhat. And you can pass that information along to the receiving, because the short time hopefully the short time that you spend with them, getting them to a certified reperfusion center. Some agencies are able to actually transmit their EKGs to the receiving. They can read it and confirm as well. As Ms. Denise said earlier, there's a 90-minute window there that they would like to have you from the time you have the pain to the time that you're in the cath lab. It increases your chances for a wonderful outcome, and that's what we're doing. You know, everything that we do is to improve the overall outcome of the patient. So, with the 12 leads, we look for elevation, irregularities, differences in the timing of the P, the PR interval, the QRS, and the ST segment. What they call a STEMI is the ST elevated. So your ST segment will be elevated. It doesn't return back to baseline. So for the parts of the heart that are affected, I like to use IC all these: inferior, septal, anterior, and lateral. It's just a way that I learned. I think it works pretty good. And so, is the location important?
Yes.
Yeah. It will help define your treatment and improve your patient outcomes. If you stop and think about it, an inferior wall MI has basically a volume problem 90% of the time. So you've got low input to the heart, so it reduces the output. So if you increase the volume, you increase the input to increase the output. Of course, there's always, standardized treatment for chest pain in this state is aspirin, oxygen, and nitro. We give the aspirin. The aspirin. First of all, we ask them what? Allergies, meds, and if you've taken any erectile dysfunction medications. A lot of people won't tell you that they actually have. They'll wait. So it's best to, if you have to, get that patient on a one-on-one and explain to them that they have, and you give them the medication that it could actually cause them a lot of damage and even death, because it's going to continue to vasodilate, and it's going to continue to lower the preload side of the heart. I don't think you can give too much fluid for an inferior wall, because it needs so much. And the best way to do that, to know the location in the field, is through an EKG. Plain and simple. STEMI versus a non-STEMI. EKGs look at the STEMI. You can't see a non-STEMI on an EKG because it's not elevated. I mean, elevated, the ST segment is normal. It's not going to show an abnormality to it at all. The treatment for a STEMI versus a non-STEMI in the field is going to be the exact same. You really say cardiac pain, it's my chest hurts, is radiating down my arm, I got an elephant on my chest, I can't breathe. It's going to be the exact same treatment. The only way, like I said earlier, that they're going to be able to tell is through labs when they get them to the hospital. The new onset left bundle branch block we treat the same as a STEMI, as a ST elevated myocardial infarction. We do that because it has pretty much the same effects. So if you have a patient with a new onset of left bundle branch block, there are plenty of patients out here that have it. And you will ask them if they have any issues, cardiac problems. They'll tell you no, and when you do the EKG, you'll look at it and go, wait a minute. They'll go, oh yeah, I forgot about that. Happens all the time. They don't consider that a cardiac problem because they don't really treat it or take anything for it. So they kind of forget that it's all there. So why do we give the oxygen for a MI, Shane? perfusion because the heart's being deprived of oxygen. So you give it some. If your patient's at 95, at 94, 95% on room air, put them on a nasal cannula. It's not going to hurt them at all. It's actually going to be very beneficial because it has that supplemental oxygen there. We give the aspirin for what?
It's an antiplatelet inhibitor.
That's correct. So it kind of inhibits the clots and the platelets from forming, and helps kind of reduce the risk of an additional blockage, if you will. And what do we give the nitro for?
Vasodilation.
Vasodilation. What are the two contraindications of nitro?
Erectile drugs.
If the patient's systolic BP is under 100.
Right. That's because of the preload issue again.
Mm-hmm.
Most of your inferior wall MIs will show that. Yes, sir.
A quick question: if I have a patient who's like, because I'm a little skittish when it comes to that. If I have a patient who's like 106, 108, around that range,
Give it to them.
give it to him.
Give it to them. If you have any doubt, please contact medical control. If you have a question and you see something funny that you don't understand, by all means contact medical control, and they can offer you some insight. It's just an extra brain if you need it. They're only a phone call away. So let's talk a little bit about the arteries. The heart, I call it greedy because the vessels come off the aorta. Your right coronary artery, your circumflex, and your left. Everything comes off the aorta. So when the blood leaves the heart and comes out of the aorta, before it goes anywhere else, it feeds itself. That's why time is tissue. You've got to get it fixed, get it corrected. The nitro is going to help open it up some, and the extra oxygen that you're giving them is going to help. They've got a 90% blockage, and you open it up just a little bit and throw some more oxygen. It's all going to help them. It's going to buy them a little bit more time in that 90-minute window. Now you can be over the 90-minute. That doesn't mean that they won't go to the lab. That 90-minute window is a study that's been done that they say is the ideal time. So as these vessels come out of the aorta, they just kind of wrap around the heart. Now there are some people that actually have extra feeder vessels. So for people who wonder how much somebody can have 99% blockage and still function, sometimes the heart will grow vessels, extra ones, if you will, that seem to work great, and it's really helpful. It saves a whole lot of lives. Do we know that they're there? No, not until we go into an actual cath, a cabbage, and we'll get into that in a minute. As we look at the locations, so these arteries feed. So by knowing the location, we can probably tell you which artery is feeding what. So in the field, it's not going to mean the world of difference to you, but in the grand scheme of things, the information you can backfeed to the receiving doctor, you can transmit that EKG to him, you can tell him what's going on. It increases the outcome for that patient. It helps them immensely. So when it's all said and done, your field knowledge of knowing where and how to locate that MI is huge when it comes to the outcomes of these patients. So there is the reason why I tell you that it's all for the field is based on the EKG. The SA node is the primary pacer for the heart, and it beats at what?
100 to 120 times a minute.
60 to 80.
60 to 80.
60 to 80. That's a normal range. So then it goes down to the AV node. AV node goes 40 to 60. Okay. Then it goes into the bundle of hits. When it goes into there, it drops down even lower. So while looking at the EKG, you can see if it's firing at the correct rate and there is no actual block in the electrical system. The MI basically is a block in the plumbing system of the heart. The electrical system will show you where the block is because it creates a problem. So it'll show you that. But it's either gonna with the heart, it's a plumbing issue or an electrical issue. We fix the electrical issues with a external pacer, right? We can fix that. Plumbing, you really can't go in there and redo a pipe. Basically, is what they're going to do. If you take them to the cath lab and it's a blockage and it can be stented, put in a stent and just open up that vessel, and it lets the blood flow. If they can't, they send them. They go in and they have what we call a cabbage, which is a coronary artery bypass graft. So they actually graft a vessel on where that blockage is, so it'll continue to feed the heart. So what I learned is that being upstairs in the ICU a day or two was that recent patient with a cabbage, if they code and require epi, you can't give them a full dose of epi. You have to give them a reduced dose of epi because it's going to blow that graft off. I was unaware of that, so that was a learning moment for me. Yes, sir.
So when you're on the street and like you have that situation, would you like, because it's not in like the state protocol, like to give half, like they don't have a
Right.
cabbage protocol. So how would you do that? Would you still get the full dose, or would you just?
If it was it's going to depend. If it's a fresh cabbage, if they've just been discharged from the hospital within a week, a month, I would probably contact medical control and be like, hey, this is a recent cabbage, and I know if I give them the full dose of epi, it could cause a problem. And they're going to tell you either yes or no. Any deviation from the state protocol or your local protocol has to go through medical direction. They can either say yes or no. They can't eat you. I mean, it's just simple as that, guys. So if it is what it is, just say, hey, you know, I need to do this, this, and this. Always think in the best interest of your patient, no matter what it is. There's an old saying, do no harm. It also says do no harm. So the more you know, the better off your outcome will be for all of your patients. So if you go back to the electrical system, you're going to go through the SA to the AV to the bundle of hits. So that's going to show you where your issue lies in the. So 12 leads in the field show you all that good stuff. The 12 is going to show you basically where this is going to fall at. as I was talking earlier, I believe in this I see all leads. That's just how I was taught. So you have an inferior, a septal, an anterior, and a lateral. The inferior will be 2, 3, and AVF. If you've got elevation in 2, 3, and AVF, look for reciprocal changes in the other leads to help offset that. So if that's 3 leads that you see elevation in. Septal, V1 and V2. So if you got elevation in V1 and V2, you need to be thinking, I got a septal wall MI. Is one any more lethal than the other? I don't think so. I think they all are. So we'll go to the anterior. Anterior is a V3 and V4, but you also want to look for the changes. You should see some changes in V2 and maybe V5 as well. I mean, you just need to look for, if you shoot the EKG and it shows it to you, always do another one. It's best to confirm. And your lateral leads are 1, AVL, V5, and V6. So if you have elevation in your leads, you can go back and refer and say, hey, this is where the location is, which is what we're doing this class on, or this lecture on, excuse me, is on location of the MI. Because we want to know where the location is, and the best way for us to find it in the field is through an EKG. We do a 12 lead, which is normally on the left side. There are some people that do a right-sided. If you shoot a right-sided, make sure you label it when it comes off the machine, the right-sided MI. If you transmit that to the hospital, let the receiving physician know, hey, this is a right-sided, so that they can understand it and interpret it the correct way. Because it's going to give them a total different view. All the EKG does is shoot electrical. It shows electrical current going through the heart from different angles. So it tries to give you it's like a panoramic view, if you will. So it's top. It goes every axis. So inferior wall MIs usually have what? Low preload, right?
Mm-hmm.
So it's low blood pressure. Okay. Is it 100% of the time? No. But there again, this goes back to the old adage: if you treat your patient, not the machine. If your patient says, I have no pain, I'm not complaining of anything, I'm breathing fine, and they look good, and your machine is like they're having the biggest MI in the world, I can't treat you based on my machine. If you tell me I'm having chest pain, I can treat that, and we'll go from there. But if you can have an MI, I guess, and never have pain, you can be what we refer to as asymptomatic to it. How would you treat that? I would contact medical control and say, hey, my 12 lead shows I have a septal wall MI, but however, my patient is completely asymptomatic. Just letting you know, on the way in, this is what we got. Does that mean that they're having a heart attack? Probably. They're just asymptomatic. And you have some people that'll have the crushing chest pain, have a history of an MI, and the EKG shows nothing, and that's referred. And the only way to do that again, that's the non-STEMI. You have to go through the lab work to see and determine what's going on with it. How's our time looking?
29 minutes and 50 seconds.
Okay, I just don't want to run over. Thank you. So with the EKGs, okay, that'll tell us a lot. Location, location, location. But the only way, the 100% pure way for all of this to work is the cath lab. When they cath them, we're going to be able to see where that blockage is. Okay? So you call in, you can say, hey, I'm en route to your facility with a 60-year-old male, chief complaining of chest pain, radiating down his left arm into his jaw. I've given him my aspirin, my nitro, got an IV established, I got him on oxygen. It appears to be that he has an inferior wall MI, and I'm transmitting you my EKG at this time. Okay, so the doctor's hopefully going to receive it, going to look at it, going to review it, and say, okay, I got it. Okay, and he will confirm, or he will say, I don't think so, or he'll say, can you shoot me another one and send it to me. If they ask for a second one, don't doubt yourself. Okay, the worst thing you can do is not call an MI in the field because you doubt yourself. I would much rather be wrong in the field and then be right here than me be wrong in the field and then because I'm telling you, if you call it and it's not one, it's okay, my bad. But if you don't call it and it is one, the time it's going to take to assemble that team at the referring hospital to help that patient, your 90-minute window gets eaten up more. And a lot of these outlying counties that are in the country, their reperfusion centers aren't 15 minutes away. So their fastest mode of transport is by air. I would love to see the state have every hospital be a reperfusion center, but it doesn't quite work that way. It would be awesome. So, but the end result is we want that reperfusion as fast as we can, because it will lead, that infarct will go to ischemia, which is death. We don't want the tissue to die, because once it dies, tissue's dead. Cardiac tissue is very different than any other tissue in the body. So when you lose that, there's really the only way to replace it is what? The transplant. You can't just replace a part of the heart. Well, the way that things are going now, you may very well be able to. So our window is 90 minutes, right? So we want to make sure that our location for the MI is valid. So if you run it and it comes out, the machines now will tell you on top of them. When you input that into the system, it will tell you have to put the age and the sex, male, female, whatever. It's going to ask you that. So when it prints out your script, it's going to say inferior wall MI suspected or possible, abnormal EKG. Well, a lot of people put all their stock into what that printout says. You need to learn to read it and interpret it so that you can for sure say this is an MI and this is the location of the MI. Because if you don't know it, you're back at that base there where you don't notify the hospital, or you take the patient to the wrong hospital that's not a reperfusion center, so you don't call it an MI. It's it's a gas pain or something. You take them to the outside referring hospital who's not a reperfusion center, then that patient has to wait even longer to get from that hospital to a reperfusion center. That's why it's good. It's beyond good. It's in the patient's best interest and outcome for you to be able to detect the MI and the location of the MI, because the location isn't going to affect your overall treatment. But you know if an inferior wall, they have a preload issue, so you have to beef up that. So you know you may have to hang an extra bag of fluid. You don't want to overload them. You want to give them that bag and keep reassessing those lung sounds. If they get to where they're really wet, you may have to cut that back. Do you want to? No, but you may not have a choice. Because the last thing you want to do is have a respiratory issue along with a cardiac issue. Shane, what is if you're looking at a EKG and urine lead 2-3 and AVF? What do you have, buddy?
Is that a
Inferior?
yeah, inferior, right?
Inferior. Right. You're right. You're right. So, that being said, if you have a lead 1, an AVL, a 5 and 6, what is that? I know I'm using your brain. It's a lateral. So septal, we're looking at it looks like a V1 and a V2. And anterior looks like a 3 and 4. Right? So if you print it off and it comes out there, you know, you got your 4 leads, you got your limb leads. And it varies by provider. Some providers put them up here and here. They don't put them on their limbs. Some have got to have them on their limbs. It's provider preference. It matters, but it doesn't matter.
Do you get the same readings? Or are they fairly?
I have.
Okay.
I have. A lot of times, if it's a larger patient with more adipose tissue, you may have to increase the gain on the monitor to make the waveforms bigger so that you can see them. Because there's a lot of dense material to go through, if you will. It's the voltage is low by the time it travels. So you do your four limb leads, and you do 1, 2, 4, 5, 6 needs to be almost mid axillary. And I'll put 3 between 2 and 4. 3 is always my last lead I put on. It's always my last lead. I like to have them sitting up a little bit, just kind of relax, take a good deep breath. You know, don't be a lot of vigorous exercise. Just kind of rest. Let me take this picture of your heart. So once you get it, the worst thing you can do is have that patient start freaking out, because you're going to freak out the patient. Patient status is not going to get any better. So as the professionals that you are, you need to say, okay, there's a couple of abnormalities with your EKG. I'd like to take you to X, Y, and Z hospital instead of C hospital. And they'll be like, oh, okay. Some of them will actually tell you, no, I want to go to this hospital, so you have to tell them no. You know, basically, you have to take a patient wherever that they're supposed to go. Okay. If you take them to a hospital that they don't want to go to, obviously it's kidnapping. So we don't do that. So we try to talk to that patient and get that patient in correct mindset. I think if you inform them, that's why we have informed consent, because they're informed and they'll consent to it. Whereas if you take them to a hospital that they blatantly refuse to go to, even if it's in the best interest of that patient, you're still wrong. So you always have to do it in the best interest of the patient. So, Shane, when we talk about location, we're going to kind of revisit this. So, why is location important?
Because when you have an MI, your heart's like lacking oxygen, and you know each minute you're losing cells.
Sure,
so
correct.
Having a proper, not diagnosis, but you know seeing the proper things on your EKG, you'll be able to figure out which hospital is most correct for that patient.
Right.
So you want to go to a hospital that has a perfusion center that's able, you know, it's heart ready, pretty much.
So, by being in the field and being able to determine the location of the MI and passing along to the receiving hospital and taking it to the appropriate hospital improves the outcome of the patient. And once you get them there and they go to the cath lab, that's when they're really going to confirm the location of that MI, because it's going right straight to the plumbing and not the electrical problems, right? So we know how to read the EKGs. We know how to determine the location of the MI in the field. We know how to determine how the hospital would determine the location of the MI, and the importance of determining the location of the MI, and that 90-minute window in the outcomes is really what we're looking for. So the importance of all this, Hunter, is in the grand scheme of things, locating that MI is the best thing for your patients and their outcomes. That's why it's important to know how to determine it. And like I said, when you give your reports to the hospital and you call in, say, my patient, it looks like a possible inferior wall MI. You can't say with 100% certainty that it is, because you're not looking at a window in their heart, which is what the cabbage does when they make the cut and they open it up. They actually can physically see the vessels. Hence the coronary artery bypass graft. So, if you have any questions about anything about this lecture, Shane, Hunter,
So we talked about 12 leads. What about a 15 lead?
you can do them. You can do them. That's what we consider like the right-sided.
Right-sided?
And just like I said, make sure that you label that, because if you hand that right-sided EKG to that doctor, and you don't label it, he's going to think he's got a whole lot of problems.
So if I do a 12 lead on a normal patient and it shows, you know, ST elevation, in the best interest of the patient, and of course it's not going to hurt to do a right-sided
That's correct.
12, 15 lead, should you do it with every patient that you run into? Would that help give a better understanding?
Some of it, yes. A lot of it is timing. In the back of the truck, you're more in tune as to let's do all that we can so we can get this patient there so that they can correct the problem. If you have enough time, by all means, I would recommend it. But if not, you're not going to have time. So, hope you guys and girls got some stuff out of this, and thank you. Appreciate your time, and continue on. Thank you.
Thank you.